Okay. Well, welcome everyone again to pediatric teaching. And today I wanted to talk about fluid and electrolyte management in common febrile illnesses, like common illnesses like pneumonia and in malaria and in meningitis. We deal with a lot of fluid management issues every day. And there's many things we can discuss about fluid and electrolyte management. And I particularly wanted to discuss a couple of issues today about the complications that can occur in fluid management in these illnesses. We'll talk about other aspects of fluid management at a later date, but I wanted to start with a background of the pathophysiology, because many people who are doing their part one, for example, this year, whether it's in pediatrics or other areas, will be learning about the pathophysiology of febrile illnesses and the pathophysiology of fluid and electrolyte management. And I wanted to link the pathophysiology, to the management decisions that we make every day. And so that's what we'll talk about today. There's another lecture online about some of the other aspects of fluid and electrolyte management, and you can look at that at some stage. But we'll go through what we're going to discuss today. To do this, I wanted to really be complete about the pathophysiology of common febrile illnesses like pneumonia or meningitis or malaria or fever itself or some other sepsis or infection, other febrile illnesses, so that we could really understand all that is to know about fluid therapy and about electrolyte imbalances that occur in these conditions. And so I did this search on these search engines, so mostly on PubMed, but on other search engines as well. That's just the background to how I prepared this lecture. It's what we'll talk about is the body water and electrolytes. So we'll talk about some physiology, some pathophysiology, and some clinical aspects. So the first thing we'll touch on is the body water and electrolytes, and how the body water is distributed and how electrolytes are distributed within the body. I wanted to talk about febrile states, so febrile conditions, fever conditions in children, and how that affects body water distribution, because it affects it in many ways. One, it can cause dehydration in common infections, and it's not all dehydration is related to vomiting and diarrhea. Some of it's related to other mechanisms, which I'll explain. I wanted to talk about mechanisms of edema in common infections, because when we look after children with common infections like pneumonia or malaria or meningitis or sepsis, then often they develop edema, and that has significant effects on their outcome. And I want to talk about the mechanisms of edema in terms of the pathophysiology of these common infections. I want to talk particularly about hyponatremia, so low levels of serum sodium, and we'll touch a bit on hypernatremia. One of the main mechanisms of hyponatremia in common infections like I've described, pneumonia or bronchiolitis or meningitis, is high levels of antidiuretic hormone, which circulates in febrile illnesses in children, and it changes our body water distribution and the way our kidneys and the rest of our body manage water. And so I'll talk about antidiuretic hormone, and I'll talk about other causes of hyponatremia, having a low serum sodium, and the consequences of that to children. I'll say something about maintenance fluids, because we probably hear a lot about maintenance fluid and how to calculate it. But I want to say something about the relevance to seriously ill children. Maintenance fluids were calculated largely for well children, but I want to talk about the relevance to seriously ill children and how that should change, how we should change our approach to maintenance fluids for seriously ill children. The sicker they are, the more affected they are, and the less they are likely to need full maintenance fluids. I'll briefly touch on, as part of this search, I looked at coronial evidence, because there are a lot of adverse events that relate to fluids that have been documented in coronial evidence. And I think it's useful just to review that. And then lastly, at the end, or close to the end, we'll talk about implications for clinical practice, because of all of this evidence about pathophysiology and about adverse events. We need to decide, well, what does that mean for us as clinicians, and what should we do? What should we do? Yeah. Okay. First of all, body water and electrolytes. And I think most of you know this, but the body water is, well, in an adult, we're about 60% water. In a child's about 70% water. So that's mils per kilogram. And in a neonate, it's around about 80% water. And that water is distributed in various compartments in the body, in the intracellular fluid, that is the fluid within the cells itself, in the extracellular fluid outside the cells. And of that extracellular fluid, then some of it is in the intravascular compartment in the blood vessels, and some of it is around the cells in the interstitium. And the proportions of the fluid that's in the intracellular, extracellular, intravascular, and interstitial fluid, that changes with age, but it's kept stable at any given age by endothelial and cell membranes. And those cell membranes and the endothelium of blood vessels, they keep the fluid in. There are also electrolyte pumps which regulate whether sodium or potassium or water crosses cells. It regulates whether glucose crosses cells, and it regulates whether water stays within blood vessels or outside. So there are electrolyte pumps. There's the oncotic pressure of the intravascular space, that is the amount of proteins, because that draws water back into the intravascular space. And of course, when that oncotic pressure is low, then the fluid leaks out into the tissues. So between the cellular membranes, between electrolyte pumps, between the osmotic and the oncotic pressure, they're all the things that keep the body water in the state of equilibrium that it's usually in. That there's these proportions of fluid in the intracellular, extracellular, intravascular, interstitial space, they remain remarkably constant, although they change with age, but they remain remarkably constant in a patient, in a child, unless there's some disturbance of the things that I've mentioned, the cellular membranes, the electrolyte pumps, the osmotic pressure, or the oncotic pressure of the blood. So just remember those things as basic pathophysiology and what maintains our electrolyte and water homeostasis or equilibrium within the body. Now, I wanted to talk about the reasons why children may get dehydrated in common febrile illnesses. And of course, most commonly, the most common cause of dehydration is diarrhea and vomiting. But if you set aside children with gastroenteritis, many types of febrile illnesses, there is reasons why children will lose water. And so even if you think about children who don't have vomiting and diarrhea, but have other states of a high fever, then they can lose water through the skin, through fever and perspiration, and they can lose water through the respiratory system because they're breathing fast and they're losing a lot of water through their respiratory secretions, the humidification that occurs. Many children who have febrile illnesses have reduced intake of fluid. So they might have been sick for 2 or 3 days and they'll have reduced intake of fluid. For example, if they have reduced conscious state or they have severe respiratory distress so that they're not drinking well, they will have reduced intake of fluid. So they may get dehydrated over a couple of days if they're not drinking as well. And then thirdly, children with some serious febrile illnesses will have what we call third spacing of fluid. That is, instead of the fluid being in the normal compartments of the body and only in those compartments and not extending out beyond those compartments, then many children with febrile illnesses will have third spacing, which is extravasation or leaking of fluid from the intravascular space to the extracellular fluid to the interstitial space. And that leads to the edema that we see in some children with severe infections like severe sepsis, or sometimes with severe pneumonia. You see children with edema. especially if they've got malnutrition as well. And that can lead to fluid collections in the tissues. So you see edema in the lower limbs or in the hands or in the face, particularly around the eyes. But it can also lead to fluid collections in the pleural space or ascites, and because the fluid leaks out of the intravascular space, it can also lead to hypovolemia. That means intravascular dehydration or intravascular depletion of water. And so children may be hypotensive or hypovolemic because some fluid is leaked out into the tissues. So children can still be edematous, but have a low intravascular volume because of this leakage of fluid out of the tissues. Now, that's not the only reason why children will get edematous if they have a severe febrile illness. And I wanted to talk about the other reasons why children may get edematous. So they can be both dehydrated and edematous. And I've talked about the leakage of fluid, the extravasation of fluid, and often we call that capillary leak, where the capillaries of the endothelium become rather leaky, and that's especially the case in certain conditions. So we see it commonly in very severe sepsis in children. We see it very commonly in dengue. It's part of the dengue pathophysiology and the change that occurs over several days in children with dengue. They get a leakage of fluid outside the intravascular space that leads to hemoconcentration, as you know, and the hemoglobin goes up, often the platelet count goes down, and they have edema. Sometimes they have pleural effusions, sometimes they have ascites, and they can still be intravascularly volume deplete. But also, this capillary leak can also occur in severe complicated malaria. So not just febrile illness, but if they have severe systemic inflammation. So that's capillary leak. The most important cause that we can affect, I think, in children with severe febrile illnesses is not giving excessive intravenous fluid. And a common cause of edema in children with febrile illnesses is they receive excessive intravenous fluid relative to the amount that they actually need. Because many children with pneumonia or bronchiolitis or meningitis have high levels of antidiuretic hormone, and that causes us to retain more water. And then when you give normal maintenance fluid to those children, they'll become edematous because they can't pass that water freely in their urine. I'll mention that in a little while. There are other reasons why children may get edematous in febrile illnesses. So the reason why we don't get edematous when we are moving around and when we're normal is that our muscles are contracting all the time when we're walking or moving around, and the contraction of muscles leads to the flow of lymph through the lymphatics. It leads to the movement. Like lymphatics don't have a heart to pump them. The only thing that pumps the lymphatics is movement and muscle movement. The muscles, are close by the lymphatics. When the muscles move, that pumps the lymph back into the lymphatics flow from the extracellular fluid into the lymphatics and then up into the thoracic duct, and then that drains into the superior vena cava. So you've got the lymphatic fluid always draining back into the right side of the heart and then circulating in the blood again. If you don't have that movement because a patient's mobile or they're heavily sedated, then they won't have that flow of lymph that is normal, so they can get edematous. That's another reason they may get edematous. And then the last reason, which is also very common, is hypoalbuminemia, where the albumin level in the blood is low. And I mentioned before that the four things that keep our body fluids in equilibrium are the cell membranes, tight junctions between cell membranes, the electrolyte pumps that flow water and salt in and out, the osmotic pressure of blood, which is the osmolarity, which is made up mostly of the sodium level, and then the oncotic pressure of the blood, which is made up mostly of albumin and other plasma proteins. And so when you've got a febrile illness that leads to a lowering of the albumin level, then that's why children will often get edematous. And we see that more commonly, of course, in children who have malnutrition, severe acute malnutrition or chronic malnutrition, where their albumin level is very low because of undernutrition, protein loss, and they will often be edematous. That's what you see in kwashiorkor. So if you have a child who's got kwashiorkor and they've got a febrile illness, then their albumin level may be very, very low, and that just means that the blood vessels can't keep water inside, and the fluid of the water leaks outside. The red cells and the white cells, they stay in the intravascular space, but plasma leaks out of the blood vessels into the interstitial fluid. So for all these reasons, edema can occur. And so when you're looking after a child, you need to think about, well, what are the reasons why dehydration might occur in this child, and what are the reasons why edema might occur in this child? Okay. I wanted to say something about this idea of antidiuretic hormone and how our body handles water in pneumonia particularly, because there's quite a bit of evidence of this. In fact, and you might know that Hippocrates, the Greek physician, was the first person to describe pneumonia, and he described one of the key features of pneumonia being high-coloured and scanty urine, right? You wouldn't think that that was a key feature of pneumonia, but high-coloured means it's highly concentrated, and scanty means it's very limited in volume. So when you see a child with pneumonia or with bronchiolitis, often you ask their parents, and they have not passed urine for 8 or 12 hours, sometimes even longer. And it doesn't mean they're in kidney failure. It usually just means their body is hanging on to water. And the body's usually hanging on to water because if a child's in respiratory distress, they can't drink as much. So instead of drinking more, their body hangs on to water, free water. And it does that through increased levels of antidiuretic hormone. Now, this is all the research evidence that supports this, but we know that in pneumococcal pneumonia, so bacterial pneumonia, that free water excretion by the kidneys can be reduced by down to 25% of the baseline in the first 9 hours. So when a child's sick with pneumonia, they may only pass 25% of a normal urine. Now, you want them to pass more because you don't want them to go into kidney failure, into have an acute kidney injury, but that's what happens commonly, that instead of passing the normal amount of urine, they may reduce their urine output because they've got high ADH and they're hanging on to water. And if you give children with pneumonia, pneumococcal pneumonia, their normal maintenance fluids, then their body weight expands by over 10% in the first 9 hours. Why? Because their body can't handle the extra water. It's not extra normal compared with what they're normally getting, but it's extra compared with what they need when they're sick with pneumonia. And so there's some good studies in India and elsewhere done looking at this, looking at fluid retention in response to pneumonia, and finding that most children will retain water. You see it also in children with bronchiolitis. There's good evidence that this concept of free water excretion, which means that can our body get rid of just water? Well, it's 15 times greater after a child's recovered from bronchiolitis than during the first 3 days. And what that means is that babies with bronchiolitis, they hang on to water because they have high ADH levels, and it's because they don't need so much, they're not able to take so much breast milk or other fluids, and therefore their body compensates that by hanging on to water. So that's what happens to babies with bronchiolitis and pneumonia. In meningitis, we know that if you give children 100% of their normal maintenance fluids, then those children will get edema. Many of those children, at least a quarter, will get facial edema. They'll get edema around their eyes, and those children have a much higher risk of a poor neurological outcome. This was a large trial that we did a long time ago now, but it's still the case today. If you give children with meningitis 100% of their normal maintenance fluids, then they'll get edematous and they'll have a worse outcome. I wanted to just talk about the frequency of hyponatremia in pneumonia and in meningitis and in malaria. I won't go into all the science or all the evidence for this, but these are all the studies that have been done looking at the how frequent hyponatremia is. And these are, you think about hyponatremia as anything less than a serum sodium of 135. As you know, the normal is 135 to 145, but less than 135, well, about a quarter of all children have a serum sodium less than 135. And if you look at children with moderate or severe hyponatremia, then that occurs in about 10%. So it's very common for children with severe pneumonia to have low levels of serum sodium. And it's associated with worse outcomes. The worse the pneumonia, the more likely they are to have hyponatremia. And I'll explain why that is in a little while. Similarly, in meningitis, the frequency of hyponatremia is even more. So we know that some sort of hyponatremia occurs in 60% of children with meningitis. It might be mild, moderate, or severe, but it's at least 60% of all children with meningitis. In malaria, there's not as much data on it, but hyponatremia is very common, and it can be just like in pneumonia and meningitis. It can be mild, commonly mild, like 130 to 135. In severe hyponatremia, so less than 130, still occurs in 20% of children with severe malaria in Africa, and many children with severe malaria have dehydration, from coexistent diarrhea or fever, or the other mechanisms I mentioned of dehydration. They may also have kidney impairment because of dehydration, and they often have a high level of antidiuretic hormone. And so I won't go through all of this, but again, hyponatremia is very common in severe malaria and in pneumonia and in bronchiolitis and in meningitis. And children with hyponatremia have a worse outcome than if they don't have hyponatremia. This is what can happen to children with hyponatremia. This was a child who had a serum sodium of 116, a previously well child who developed cerebral edema. Now, for those of you who can read CT scans or are used to looking at CT scans, you can see how swollen this brain is. The normal sulcal and gyral pattern is gone. The ventricles are very minimal, and you can see how swollen this brain is. And that's because the child had a serum sodium of 116. And if the serum sodium is very low, remember that's the osmotic pressure of blood. We talked about the oncotic pressure being the albumin level, and this is the osmotic pressure being the usually mostly made up of the serum sodium. And if the osmotic pressure is low, then water leaks out of the blood vessels into the interstitial fluid and into cells, and that can lead to cellular edema, like we see here, and cerebral edema. So there's been, unfortunately, many children die from this complication with common febrile illnesses, and I'll mention that in a short while. The mechanisms, as I mentioned, mostly it's high levels of antidiuretic hormone and children given large volumes of intravenous fluids in conditions that we know to be associated with high levels of ADH. So in pneumonia, in bronchiolitis, in meningitis, in sepsis, post-operatively, in previously well children who present to hospital and have surgery and get the wrong sort of fluid and they get too much fluid, they also may have high levels of ADH. And that can lead to hyponatremia and edema if they get the wrong sort of fluid. There's a couple of other reasons why children might have hyponatremia in common febrile illnesses, and we can see that sometimes in tuberculous meningitis, where they have a condition called cerebral salt wasting. So instead of retaining water, they lose more sodium, and that's a condition that's mostly described in children with tuberculous meningitis and other complications like communicating hydrocephalus from TB meningitis, etc. Lots of inflammation around the brain in a sort of more chronic meningitis. There's also another mechanism and it's not antidiuretic hormone, but it's atrial natriuretic peptide. I won't go through it too much, but it's in pneumonia. There is, as you know, if you've got pneumonia, then often your pulmonary vascular resistance will be higher. Pulmonary hypertension is a problem. Therefore, you may get stretch on the right atrium because of the higher pressure in the right atrium or higher blood volume. And that can lead to a release of a hormone, a peptide called atrial natriuretic peptide. And what it means is it's released from the atria. It causes a natriuresis, which just means sodium loss in the kidneys. Natriuresis means sodium loss in the kidneys. And so again, like cerebral salt wasting, there is a increased sodium loss. And so the cause of hyponatremia in some conditions can be more complicated than just high levels of antidiuretic hormone, but it can be due to these other mechanisms as well. But most of the hyponatremia we see is a combination of high levels of ADH and the wrong sort of fluid being given to children. As you know, antidiuretic hormone is stimulated by the posterior pituitary, and it can be stimulated by hypovolemia, hypotension, dehydration, hypernatremia. So if the sodium level rises, then you get more antidiuretic hormone being released. They're the normal mechanisms for ADH release, but ADH release can also be triggered by certain illnesses, and I've mentioned those: meningitis, particularly pneumonia, bronchiolitis, sepsis, anesthetic drugs, even surgery, burns. We've seen this in, and ADH acts on the collecting duct of the renal tubules and stimulates these things, these tight junctions called aquaporin receptors, and that enables water to flow from the collecting duct back into the interstitial space, and therefore instead of passing a more dilute urine, you pass a more concentrated urine because ADH retains the water, and you just then excrete the solutes in a concentrated urine. All right, so it's just important to know what ADH does and in what circumstances is it normally stimulated, and in what circumstances is it pathologically stimulated. What's the pathophysiology of fluid and electrolyte changes in meningitis and common febrile illnesses like that. On the other side, hypernatremia, so high levels of serum sodium, aren't nearly as common. And I'll just summarize this here, that mostly hypernatremia occur in the setting of diarrhea. And there are certain, in certain very humid environments, in tropical environments, and hypernatremia can occur simply because the child is losing more water than they're losing salt. Right? And so especially if they've got diarrhea and they're losing a lot of water and not losing as much salt, then their serum sodium will go very high. But it really only occurs in 2 to 6% of meningitis. It only occurs in pneumonia if there's coexistent diarrhea. You can see that after a child's had an acute kidney injury, then when their kidneys are starting to recover, they start to urinate a lot of highly dilute urine, and they're passing lots of water, and so they can get hyponatremic. Sometimes hyponatremia is due to a hospital-acquired thing, iatrogenic problems like in salt poisoning. So in some circumstances, and occasionally if parents make up formula in the wrong way and don't add enough water to it, then a child will have a salt-like poisoning. This is what happens when a child has severe hypernatremia. This was a neonate with severe hypernatremia, and you can see that instead of having cerebral edema, perhaps you can see the picture, but this child had an extremely sunken fontanelle, and the sutures were overlapping, and that's because the baby's brain had shrunk. And when a child has severe hypernatremia, then you get shrinkage of the brain tissue. Remember, with severe hypernatremia, the fluid leaks out of cells, back into the intravascular compartment, and that leads to shrinkage of cells and sometimes because of the shearing forces on blood vessels within the brain, you get strokes or you get cerebral bleeding, hemorrhage. And this is again a child with a severe hypernatremia who had strokes related to that. You can get venous sinus thrombosis because just think of which way the water moves. If there's hyponatremia, the water moves into cells. If there's hypernatremia, the water moves out of cells, trying to normalize the serum sodium. And so on the one hand, with hyponatremia, you can get cerebral edema. On the other hand, with hypernatremia, you get cerebral shrinkage and hyperviscosity of the blood and sometimes strokes. Again, but not nearly as common as hyponatremia. I wanted to talk about potassium changes. And of course, the most common reason for potassium changes, hypokalemia, low serum potassium, is in diarrhea. And we see that a lot, don't we? In children with diarrhea, especially if they've got coexistent malnutrition, then hypokalemia is almost occurs in about half the children. It's much less common in pneumonia, hypokalemia. And one study showed that it was less than around about 10%. So 10% only had mild hypokalemia. 7% of children in India had hypokalemia. And in severe malaria, again in Kenya, hypokalemia occurred in 14% at the time of admission. But in those children, they received an intravenous fluid that didn't have potassium replacement, and the amount of the proportion of children with hypokalemia increased from just 14% to 39% on day 2. So we can induce hypokalemia if we don't give potassium replacement to children. So all children with whose kidneys are functioning and have a febrile illness where they need intravenous fluids need a source of potassium. So whatever fluid we use should have some potassium in it, unless the child's having an acute kidney injury. And then, of course, they don't need it because they retain potassium. So we've talked about the pathophysiology of edema. We've talked about dehydration. We've talked about hyponatremia and hypernatremia and hypokalemia. I wanted to now talk about this concept of maintenance fluid, because we are taught maintenance fluid in children, and it's the 150-20 rule or the 4-2-1 rule. And what you need to understand is where that rule comes from. Well, it was worked out in the 1950s, so a long time ago now, but worked out on well breastfed infants, so a healthy breastfed infants. And it was the amount of water that was required by a child who's physically active and normally metabolizing to excrete all the wastes we produce in a urine that's what we call isoosmotic. So it's not too concentrated, not too dilute. So just a normal sort of urine, right? So the kidneys don't have to work too hard to concentrate or dilute the urine, but that's the amount of water and solute that's required. And that's been what we've historically used as a way to decide the amount of maintenance fluid a child requires. And so that led to the 150-20 rule or the 4-2-1 rule. You'll be familiar with that. 100 mils per kilo for the first 10 kilos, followed by 50 mils per kilo for the next 10 kilos, and then 20 mils per kilo for every kilo thereafter. That's the 150-20 rule. And Holliday and Seeger, these scientists in the 1950s, also identified the amount of sodium that children... Oh, excuse me, I'll need to get that phone call. So I'll just be a moment, yeah. Let me just... Okay, so we're talking about how the maintenance fluids have been designed on well children, and the amount of water and sodium and potassium has been identified. That was a long time ago, but based on that, we used to use this fluid called 4.3% dextrose and 1/5 normal saline. And many of you might still have that. Some of you might still have that in your hospitals. And theoretically, that gives you the right amount of water and salt and glucose. But the problem is it's not appropriate to children who are very sick. And a lot of complications have occurred because of that fluid. And the reason is that while the amount of fluid that the 4-2-1 rule, the 150-20 rule, was identified for children who were well, but many children who are sick have high levels of antidiuretic hormone that is there because they're not metabolically active, so they're not using up as much water, and they may be like in severe respiratory distress or in decreased conscious state, so they'll have reduced requirements for fluids. And if you give the normal maintenance fluid to such children, then they'll get edematous and they'll get hyponatremic, low levels of sodium, and they'll get they may get cerebral edema. There was, as I said, to prepare this talk, I looked for cases around the world where this had happened, and there's about 50 cases worldwide of deaths or permanent brain injury in children because of hyponatremia occurring because of the use of this fluid, this 4.3% dextrose and 1/5 normal saline. And there's been a number of coronial inquiries in especially in the United Kingdom, in Canada, in Australia, in other places that used to also use this fluid, 1/5 normal saline, and so now most countries don't use that fluid. What they use is a different sort of fluid, and most countries have gone away, and WHO has said that this fluid, 0.18% sodium chloride and 4.3% dextrose, shouldn't be used, but it's better to use something like lactated Ringer's solution or Hartmann's solution. They're more or less the same fluid. Or there's another fluid called plasmolite, which is also similar. And if you haven't got that, then use normal saline with glucose. The problem, normal saline is not ideal because it's got a lot of chloride in it. It's a rather acidic fluid, and you're better off using something like Ringer's lactate with glucose or Hartmann's solution with glucose. When we talk about the sorts of fluids, then it's useful to know that this old fluid, 0.18% saline, is a hypotonic fluid. Normal saline is an isotonic fluid, and Hartmann's solution is isotonic and a balanced salt solution. So it won't lead to hyponatremia, and it also has some other salts in it, other electrolytes that are helpful for sick children. So the main messages from all of this, from what we've discussed today, is that fluid and electrolyte imbalances occur commonly in many conditions of children that we treat every day: pneumonia and sepsis and bronchiolitis and meningitis and dengue. These fluid and electrolyte imbalances occur commonly, and when we don't test for them, then we don't know that they're occurring. And so it's important to try to limit the effect of those electrolyte imbalances on outcomes for children. We should, if possible, prioritize enteral feeding. Feed the child via orally or via a nasogastric tube, or allow them to breastfeed. That's much better than providing intravenous fluids, which can cause all of these problems. But if we're going to prescribe intravenous fluids, then we need to do a clinical assessment for signs of dehydration. Remember I said it's very common. For signs of edema, for their nutritional state. We need to calculate the fluid required for their maintenance and make sure it's not, if it may not be 100% of their normal maintenance, but maybe a bit less than that. And we need to calculate any replacement of any deficit or additional fluids for ongoing losses. And we need to take into account the total fluid intake the child has, because sometimes that will be the intravenous fluids we prescribe plus drug dilutions that the child receives and oral feeding and other things. And so the total fluid intake may be quite a bit more than what we actually think we're giving when we give intravenous fluids. And if we are giving intravenous fluids, then instead of using the 150-20 rule, to avoid fluid overload, we should sometimes reduce the fluid to 50 to 70% of the original maintenance fluid. And we should use a balanced salt solution like Hartmann's solution or Ringer's lactate or Plasma-Lyte, and not use 0.18% saline. And we should make sure that the fluid has a source of glucose in it. And for children that, for all children on intravenous fluid, we should monitor for signs of dehydration and edema at least every day, usually twice a day. And because these disturbances, edema, dehydration, hyponatremia, they're very common and they're also dynamic. They change, and so frequent reassessment of the amount of fluid you're giving a child is really important. And any child who's on intravenous fluid should have daily or second daily checking of their serum sodium and their potassium and their glucose, if you can. And especially if you're not able to give the ideal sort of fluid, the best fluid like Hartmann's solution or Ringer's lactate. And we need to, I think, educate more health workers, nurses and junior doctors about the fluid and electrolyte imbalances that can occur in common febrile illnesses, and to know which fluids are safe to use, and train them in how much fluid to give, and a clinical assessment of their hydration state, looking for edema and dehydration. And that should be a part of all the education we give to healthcare workers. So that's all I want to say today. It's really just the start of fluid and electrolyte imbalances. And I'm sorry it was broken in the middle by a call I had to take, but I hope that's been useful to you, and I hope you'll learn a bit more about fluid and electrolyte imbalances. We'll talk a bit more about it next week, I think, but I hope that's been useful. So I'm happy to answer any questions that you might have, or we'll leave it at that.